Today I am going to tell about the contracted pelvis and cephalopelvic disproportion. So this is the pelvic bone. Pelvic bone we have sacrum, ilium and coccyx. So this is the sacrum promontory, both ilium bones, sacrum, ischial spines, coccyx, pubic bones. This in between that both pubic bones is the pubic symphysis, pelvic brim, anterior superior iliac spine and iliac crest. So these are the diameters of the pelvis. Pelvic inlet anterior posterior diameter is 11 centimeters, transverse is 13 centimeters and oblique is 12 centimeters. And pelvic cavity is anterior posterior diameter is 12, transverse is 12 centimeters and oblique is 12 centimeters. In the pelvic outlet, anterior posterior diameter is 13 centimeters and transverse is the 11 centimeters. So this is the pelvis. How do we assess the pelvis? Is from the pubic symphysis, pubic bone to the uh, sacrum promontory. From the lower part of the pubic bone to the sacrum promontory is called the diagonal conjugate. And from the midpoint of the pubic bone to the sacrum promontory is called the obstetric conjugate. And from the upper part of the pubic bone to the sacrum promontory is true conjugate. So diameters of the pelvic inlet. So anterior posterior diameter, that is true conjugate from the sacrum promontory is to the superior margin of the pubic symphysis, that is 11.5 centimeters. Diagonal conjugate is from the sacrum promontory to the inferior margin of the pubic symphysis is 12 centimeters. Obstetric conjugate is sacrum promontory nearest point on the posterior surface of the pubic symphysis is 10.5 centimeters. Types of pelvis. There are 4 types of pelvis. One is gynecoid pelvis, petipelloid pelvis, android pelvis and anthropoid pelvis. So type of pelvis is determined by the posterior segment. Table. Features. Pelvic inlet. In the gynecoid pelvis it will be the circular. In the anthropoid pelvis it is oval. In the android pelvis it is wedge shaped. In the petipelloid pelvis it is oval. Anterior segment equal and spacious, slightly increased, narrow, short and flattened. In the posterior segment equal and spacious, more increased, short and flattened. Cavity and side walls are straight or slight divergent, straight or divergent convex. The sacroiliac notch wide and shallow in the gynecoid pelvis, more wide and shallow in the anthropoid pelvis, narrow and deep in the android pelvis. So features is outlet ischial spine. It is not prominent in the gynecoid pelvis, not prominent in anthropoid pelvis, prominent in android. Petipelloid is not prominent. Subpubic arch is wide, medium, narrow and wide. Obstetric outcome is easy and normal delivery, occipito-post anterior or direct occipito-posterior face to pubis delivery is common. So occipito-transverse or posterior deep transverse arrest may need emergency LSCS. Occipito-transverse delayed engagement and vaginal delivery. Contracted pelvis. So what you mean definition of the contracted pelvis is anatomical definition. It is a pelvis in which one or more of its diameters is reduced below the normal by 1 or more centimeters, 1 or 1.5 centimeters. So obstetric definition is it is a pelvis in which one or more of its diameters is reduced so that it interferes with the normal mechanism of the labor. So CPD can be due to large baby or contracted pelvis or both. So Cardwell and Muller's classification is based on the shape of the pelvic architecture. Commonly mixed types are found. Android, anthropoid or patibular are not any diseased pelvis. Pelvis which are not typically gynecoid need not necessarily be contracted. So type of contracted pelvis can be contracted at pelvic inlet, cavity or outlet, or could be generally contracted pelvis. Mid-cavity and outlet contractions go together usually. If there is contraction in the mid-cavity, usually there will be contraction in the outlet also. Inlet contraction measured by diagonal conjugate unengaged head at term in nulliparous. Mid-cavity contraction suspected by narrower interspinous diameter less than 10 centimeters. Malposition is common. Outlet contraction intertuberance diameter is 8 centimeters or less 4 knuckles. Subpubic arch is Gothic normal. Etiology of the contracted pelvis. Nutritional. Nutritional it will be rickets, osteomalacia. Vertebral deformities. Kyphosis, scoliosis, spondylolisthesis. Disease or injury to pelvic bones. Fractured pelvis, tumors of the pelvis, sarcoma. To disease or injury of the lower limbs. Fracture and dislocation, poliomyelitis, tuberculosis of hip joint. Developmental defects are very rare, like split pelvis, necklace pelvis, absence of one ala of the sacrum, Robert's pelvis. So diagnosis of the contracted pelvis. So medical history. Rickets is expected if there is a history of delayed walking and dentition. Trauma or disease. Type of pelvis, spines or lower limbs. Obstetric history. Prolonged labor ended by difficult forceps, cesarean section or stillbirth. Weight and outcome of the previous child. You have to take all these histories. So diagnosis of the contracted pelvis. General examination. Gait. So we have to see the gait of the patient. Abnormal gait suggesting abnormalities in the pelvis, spines or lower limbs. Stature. Women with less than 150 centimeters height usually have a contracted. Spines and lower limbs may have disease. Abdominal examination. When we do an abdominal examination, that there will be pendulous abdomen will be there, malpresentation will be there, and unengaged head at term in a primary gravida we can see in an abdominal examination. Causes of unengaged head at the term in a primary gravida. So assessment of the pelvis. How do we assess the pelvis? By pelvimetry. Clinical pelvimetry is X-ray pelvimetry, not done usually in any clinical practice, and CT pelvis not done generally in a clinical practice. MRI is not done. External pelvimetry, there is no role in the modern obstetrics. So clinically pelvimetry is the most important method of the diagnosis of the contracted pelvis. Fetal head is the most important pelvic method. So how do you assess the pelvis? First, on the digital examination, we have to pass our 2 fingers into the vagina and under aseptic precautions, then see whether you can reach the sacrum promontory or not. So usually we can't reach the sacrum promontory. We Then if we reach the sacrum promontory, there is some contraction in the pelvis. So usually it is not done. Then we have to see further sacrum is well curved or no. Then we have to see further sacrosciatic notch and the side walls, suprapubic arch angle, and then whether the outlet is admitting 4 knuckles or not. Disproportion. So this is a cephalopelvic disproportion. Disproportion is a clinical state where normal proportion between the size of the fetus to the size of the pelvis is disturbed. Cephalopelvic disproportion. So disparity in the relation between the head and the pelvis sufficient enough to alter the normal mechanism of the labor. So causes of the CPD. Average size baby with small pelvis, big baby with an average size pelvis, combination of the above two. Normal size fetus with deflection head has a CPD. Diagnosis of the CPD. Abdominal method. How do you diagnose the cephalopelvic disproportion? Patient is placed in the dorsal position with thigh flexes and separated. The head is grasped by the left hand. 2 fingers, that is index and middle finger of the right hand, are placed above the pubic symphysis to note the degree of the overlapping. If the head is pushed downwards and backwards. So this is how do you place your 2 fingers just above the pubic symphysis, and with the left hand you have to grasp the head of the fetus. So the head can be pushed down in the pelvis without overlapping of the parietal bone on the symphysis pubis. So there is no disproportion. It can be pushed down a little, but there is a slight overlapping of the parietal bone, evidenced by touch on the undersurface of the finger, overlapping by 0.5 centimeters. There is a moderate disproportion. So head cannot be pushed down, and instead the parietal bones overhangs the symphysis pubis, displacing the fingers. So there is severe disproportion. Sometimes the degree of the disproportion is difficult to found by this method causes of deflection. If there is a deflection head, thick abdominal wall, irritable uterus, high floating head, in these conditions we can't diagnose the cephalopelvic disproportion. So there is one more method, abdominal or vaginal method. So it is called as a Muller-Munrocher method. It is a bimanual method. The head can be pushed. What you do here is we have to grasp the fetal head with the left hand, and we have to insert the next and 2 fingers into the vagina and put thumb on the pubic symphysis. So here the head can be pushed down up to the level of the ischial spines, and there is no overlapping. Your 2 fingers should be at the level of the ischial spines. So the ischial spines, and there is no overlapping of the parietal bone over the pubic symphysis pubis. That means there is no disproportion. The head can be pushed down with the left hand a little, but not up to the level of the ischial spines, and there is slight overlapping of the parietal bone. Slight or moderate disproportion is there. The head cannot be pushed down, and instead the parietal bone overhangs the pubic symphysis, displacing the thumb. So there is severe disproportion is there. So cephalometry, ultrasound, is the safe, accurate and easy method and can detect. So with the biparietal diameter, the occipitofrontal diameter, the circumference of the head. So radiology X-ray is difficult to interpret.